Let's go ahead and get started. Thank you everyone for coming. We have a visitor today who actually will hopefully see more of over time. Dr. Sunny Lin is a new assistant professor in the OHSU PSU School of Public Health in the Department of Health Management and Policy, and she joined PSU and OHSU, since the School of Public Health is part of both, a few months ago. And so she's establishing her research and her teaching of courses and so forth. And in fact, we'll be teaching a course in health informatics that Ted Ladaris and I originally developed at PSU, and she'll be taking over that. She is going to talk to us today about hospital health information exchange and alternative payment models, which those of you kind of in the clinical know that that's a lot of what's happening now in terms of payment and HIE and so forth. She has a bachelor's degree from Northwestern University, a master's from Carnegie Mellon, and finished her PhD at University of Michigan this past spring. And her research mentor is someone who probably many of you know or who have heard of, Dr. Julia Adler-Milstein, who actually left the University of Michigan and now is down at UCSF. So I will turn it over to Sunny.
Hi, thank you so much for having me. Let me see if this works, and I can come out from behind the desk. Yeah, it doesn't. So I'll stand behind here. I'm really happy to be here and to meet you all. I've heard a lot about the great stuff that is happening here, and thank you. And yeah, so this is just a little bit of the work that I did at Michigan. So this is a paper that was published in the American Journal of Managed Care a couple months ago. So it's actually been a while since I looked at the data, so this will be fun for me too. And I'm more than excited actually to get your feedback, response, and kind of your perspective on things. So so I kind of come at this from a policy angle, and a lot of times that can be really hard from this perspective to really understand what's going on at the clinician or the organization level, or what's going on behind the scenes in any one given organization, which is why I'm so excited to be here in this position. I'm going to give just like a brief overview of the kind of policy side of things, and I hope this is helpful, and kind of give some context to the work I'm doing. So in the U.S., care fragmentation is estimated to be responsible for about like $25 to $45 billion of wasteful spending each year, and that includes spending on things like redundant tests or avoidable hospital admissions. And so policymakers are using payment models to try to improve care coordination in the hope that some of this excess spending will kind of go away. As many of you probably know, there's both federal and state policies that are trying to tie more and more payments to what's called alternative payment models or value-based purchasing models. I think the most popular one here is the Oregon CCO 2.0 or the CCOs. Those are both examples of these kind of payment models. And technology is expected to play a large role under these programs. So here are some of the use cases: population health analytics, provider identification and communication, and health information exchange for a variety of different uses. So the research question that I wanted to address in this paper was whether alternative payment models promote greater engagement in hospital health information exchange. And I talk about greater engagement, it's a very broad term, and I'll go into that in a little bit, but whenever I talk about greater engagement, I just want you to think of the goal of getting the right information to the right person at the right time. So here's a kind of quick primer in federal alternative payment model design, which is what this paper focuses on, and I'm still learning more about what's happening here in Oregon. So as many of you know, in the US, most providers are paid on a fee-for-service basis. So here's an example with my grandmother. So say she falls and breaks her hip, and she sees a provider who gives her, who she or her insurer basically gives them a lump sum of money for whatever services were rendered. And then she's sent to the hospital for treatment, and that hospital gets some money. And then she's sent to a skilled nursing facility for rehabilitation afterwards, and that skilled nursing facility would then get some money. So under fee-for-service, the hospital has no incentive to coordinate care between the hospital and the skilled nursing facilities. A lot of them do, which is great, but sometimes if, for example, the receiving post-acute care provider is not in the same organization or under the same umbrella or health system, information can get lost. And oftentimes what that leads to is a readmission. So under a fee-for-service payment model, that hospital actually gets more money as a result of providing poor quality care coordination. So this is a big problem at a larger scale. About 1 in 5 elderly patients are readmitted to the hospital within 30 days. And this costs Medicare about $17 billion in potentially avoidable costs. And so what alternate payment models do is they create an incentive for organizations to work together to improve care coordination. So it's just got to get a sense of how big these alternative payment models are becoming. In 2017, an estimated 34% of all healthcare payments were linked to some sort of alternative payment model, whether that be Medicare, Medicaid, or private commercial alternative payment models. So I'll go into 3 of the main kind of federal APMs right now, and we can have a policy discussion about why I chose these if you're interested. But these are the big ones that Medicare is currently kind of pushing. So under ACOs, ACOs are collectively rewarded, or ACOs are a group of organizations that are collectively rewarded if care for their population comes in under a certain pre-specified amount. So organizations that share a lot of the same patients can create an ACO, and each year that patient body, the spending on those shared patients are summed. Oh, that's great. Sorry. Each year's spending on those patients are summed. Maybe this doesn't work. That's okay. And compared to a benchmark. And that benchmark is set based on historical spending in order to try to keep healthcare costs, cost increases from increasing over time. So to date, about 10% of the U.S. population is covered under some kind of ACO. So under bundled payments, this is a hospital-centric payment model. The hospitals are paid per episode, regardless of the quantity or type of services received. And under Medicare's Bundled Payment for Care Improvement Program, or BPCI, this bundled payment includes post-acute care, even if that care is received outside of the hospital. And then patient-centered medical homes are primarily primary care practices that are focused on providing comprehensive patient-centered coordinated care. And I've included this in this study because a lot of hospitals exist in healthcare systems that have a primary care patient-centered medical home, like OHSU. And so under patient-centered medical homes, payment models are often similar to either the ACO or the bundled payment models. Okay, so what role does health information technology have in alternative payment models? So here are some use cases: clinical decision support and facilitating the use of evidence-based practices, predictive analytics, patient risk stratification, and population health management. I'm sure you guys could give me all sorts of more interesting things to put on here, and I'd be interested in hearing your thoughts on that. But for this paper, what I focus on is health information exchange for the purposes of coordinating care after a hospitalization. So under the status quo, or paper-based information exchange, less than 50% of primary care providers report receiving discharge information for their recently hospitalized patients. And for the discharge information that is sent, up to 65% are missing important components like lab results or follow-up procedures, test results, and up to 88% don't actually arrive in time for the patient's first follow-up visit after a hospitalization. So this is a really big problem, and as many here in the room would probably believe, electronic health information exchange promises to improve the completeness, the timeliness, and the accuracy of the information that's being exchanged, which in theory should lead to less redundant, and better quality post-acute care. I don't know how many of you had seen this paper come out, but I thought it was fun. Dr. Atul Gawande is just a really great writer, and what he talks about in this paper is why doctors hate their computers. So even though we have all this technology, getting physicians to use it and getting the right technology to physicians at the right time is actually quite hard given all the other responsibilities that physicians have to do. So where I kind of see fleshing out my research is looking at HIT adoption and use at different levels of care. So at the physician level, it's how do we make technology accessible and easy to use for physicians and providers and staff. At the organization levels, how do we help organizations to use technology and leverage it to improve patient care? And then at the system level, which is where this paper fits in, is how do we use technology to facilitate information traveling across organizations in order to support patient care. So my prior work in this area suggests that under a fee-for-service payment model, financial incentives are a really large barrier to health information exchange. So for example, for-profit hospitals actually share information for fewer of their patients. Highly competitive hospital markets are less likely to have what's called a regional health information exchange, which is a third-party organization that helps to facilitate information exchange between organizations. And then competing providers often choose to participate in different health information exchange approaches, which limits the value that's exchanged in any one given approach. And then often, when you talk about health information exchange improving care, a big question that comes up is, well, what is the payer's role? Because in theory, the payers are the ones that are going to really benefit from this. And in this study, we talked to a bunch of payers, and we found that payers really believe in the value of information exchange, but they're cautious to invest in those information exchanges for fear of benefiting their competitors. However, alternative payment models, this is my theory, are situated to really improve the state of information exchange in the United States. And that's because these interorganizational barriers that may be attenuated by the financial models that's in these alternative payment models. So as I mentioned before, Medicare has this big goal of improving or of tying more payments to these kind of alternative payment models and value-based payment models, and really are kind of ramping up participation in these payment models. So again, my research question here was, do alternative payment models promote greater engagement in health information exchange, specifically for the purposes of post-acute care coordination? So there's been a lot of talk about the importance of health information exchange and alternative payment models, but a lot of the talk kind of focuses on other use cases, such as reporting or population kind of analytics and looking at it kind of a community level, like disease registries and those kind of things, which are important. But the extent of HIE use for the purposes of post-acute care coordination has not really been looked at. And due to a lot of the things I mentioned earlier, there is still reason to believe that even under alternative payment models, information exchange might be limited. So for this paper, I looked at 4 different dimensions of health information exchange at the national level. So the first was the volume, or the percent of patient transitions for which information was exchanged electronically. The second was diversity, or the variety of data types that a hospital says that they can routinely send to a receiving provider. The third was the breadth of the variety of partner types that a hospital says that they can send information to. And then the fourth was the depth, or the ways of accessing data. So I'll go into each of these in more detail later. And then for the independent variable, I looked at whether a hospital participated in an alternative payment model. Again, those were the ACOs, the BPCI program, or the patient-centered medical home program. So for volume, or the percent of patient transitions, I looked at the percent of patients that transitioned to another care setting following a hospitalization, and for whom information was sent via an electronic summary of care record electronically. So this came from the Medicare EHR incentive program, otherwise known as Meaningful Use. And this was for hospitals that had tested to stage 2 of that program. So the minimum requirement in order to attest successfully to this program was 10%. And as far as I know, that hasn't changed in the new promoting interoperability policy that's coming up, or has it already? Time is flying. So the second was diversity, or the data types. So I looked at these specific 4 data types based on prior literature that kind of evaluated what kind of information was most useful for a primary care provider following a hospital discharge. So the first was summary of care records, the second was radiology results, the lab results, and medical history. And I basically counted the number of these data types that a hospital said that they were able to transmit routinely to follow-up providers after a patient hospitalization. And so this came from the AHA annual survey. I'm sorry, AHA annual survey's IT supplement. The third was breadth or partner types, and that is, again, looking at the AHA IT supplement, asking hospitals to what type of provider can you send information to. So ambulatory care providers outside the hospital system, long-term care, post-acute care providers, and behavioral health providers. And then I looked at the approach, and with the idea that, well, as you probably know, there are 2 main approaches to sending information, but push, otherwise known as direct, or pull, which is using a kind of uploading all the data into a third-party database and then allowing providers to kind of download that whenever they need it. So because of how pretty much everyone has the capability of using push, I looked at whether a hospital was able to use one method or both. And really that came down to whether they could use just push or if they had the ability to use push and pull. So both are useful for care coordination, but there are studies that show that having the ability to do actually both is associated with a higher probability of that physician actually accessing the information. And again, this came from the AHA annual IT supplement survey. So this was a retrospective observational study using data from 2014 to 2015. And it used regression analysis with mixed effects with clustered standard errors at the hospital level. And it controlled for a variety of other factors that might influence health information exchange, such as the year, the size of the hospital, where the hospital was located, whether it was part of a healthcare system, whether it was owned by a for-profit or nonprofit, or a government hospital, and then some measures of patient characteristics, such as the case mix and dish, and all these things that are maybe interesting to you, maybe not. So this was basically how I got my data. So the AHA survey gave me information on hospital demographics, and then I connected that to information on whether the hospital participated in an alternative payment model from a variety of sources, including the Levitt Partners ACO database, and then data from Medicare and the AHA survey. I added some community control data from the area health resource file, and then data on health information exchange from the AHA survey and the Meaningful Use program. So my final analytic data set had about 800 hospitals in it for the volume analysis, 1,700 hospitals in it for the diversity and breadth analysis, and 1,400 hospitals in it for the depth analysis. And the reason why the depth analysis, I ended up dropping about 300 hospitals there, was because 300 hospitals actually said that they couldn't do either push or pull. And so for them, I just decided there were other things that they had to worry about. Health information exchange was probably not one of them, and it would be kind of weird to keep them in this analysis. They had other things going on. A lot of these turned out to be rural critical access hospitals and things like that. So there are some limitations, as I'm sure many of you might be thinking about already. So the dimensions are measured independently at the hospital level. So I don't really have a good way of telling, for what kind of patients was what kind of data sent and to whom. So it was really kind of aggregated at the hospital level. I have no measure of who the data was sent to, so I just know that data was sent. I don't know if it was sent to someone within the system, somebody outside of the system, a competing hospital. It doesn't really tell me. So because I was only able to get data for 2 years, I do have limited causal inference. So I can't actually say if alternative payment models lead to greater information exchange, or if hospitals that participate in alternative payment models already have greater engagement in health information exchange. And finally, I have limited generalizability. So as I mentioned, I ended up dropping a lot of small rural hospitals. And then at the same time, the volume analysis was limited to hospitals that had tested to stage 2. So here are my findings. So this is a kind of descriptive table of all the hospitals in the analysis, and it's a lot of data. And basically, the idea is that the hospitals in my sample tended to have really high participation in alternative payment models to begin with. They were more likely to be large urban teaching hospitals, part of healthcare systems, and nonprofit hospitals. So here are my effects. So these are average marginal effects, basically suggesting that for hospitals that participated in an alternative payment model, they tended to send information for 11 percentage points fewer patients. They send 0.28 more data types, 0.27 to 0.27 more partner types, and then the likelihood of them sending data with both push and pull methods versus just push or pull is about 1.6 times greater for hospitals that don't participate in alternative payment models. So to put these numbers in context, what I did was project out. So this is looking at for a average nonprofit hospital holding all hospital characteristics at their average. If a hospital participated in the alternative payment model, they would, on average, be expected to send data for about 51% of their discharged patients versus 62% for hospitals that did not participate in alternative payment models. They would be expected to send 3 data types versus hospitals versus 2.8 data types for hospitals that did not participate in alternative payment models. And then for breadth, they would be expected to send data to 1.7 partner types versus just 1.4 for hospitals that did not participate. And then for depth, the probability of a hospital that participated in alternative payment models of sending data via both push and pull methods was 80% versus 72% for hospitals that did not participate in alternative payment models. Again, this is just predicted for like an average nonprofit hospital. So I guess initially when I found these results, I thought I might have made a mistake. Like I was hoping to see kind of higher bits across all 4. But what we did find was that volume was lower for hospitals that participated in alternative payment models versus not. And what we thought might be happening here is that hospitals that do participate in alternative payment models are really focusing on it and improving the infrastructure and HIE capabilities with their affiliated partners. So especially something like an ACO, where you have specific partners that you are working with, you might hospitals might be really investing in the structures, the technical structures, and the information workflows to kind of get that information to those specific partners. And that might lead to a lower HIE volume, but greater HIE kind of depth, breadth, and diversity that we were finding. The second possibility is that these hospitals are really focusing on specific use cases. So focusing in on patients that are very complex or have chronic diseases for sending information versus just sending information for all of their patients. And finally, one thought might be that hospitals that are participating in these programs are really investing in a lot of different quality improvement efforts, and that might lead to more physician burnout or things like that, where it's just harder for providers to really get to send information or include those workflows in their routines because they've got other things going on. And I'd be interested in hearing your thoughts on that as well. So implications and future directions. So one is that, I guess the major takeaway from this is that incentive programs like alternative payment models are facilitating greater engagement in health information exchange. However, there might still be barriers to getting that information exchanged. And I think we are still very far away from that world of interconnectivity that a lot of us hope that we'll have one day. So ways to improve information exchange across organizational boundaries might be to promote patient access to data. So there's some third-party patient-facing applications that allow you to download your information and send it to specific providers as you want. And that might be becoming more popular, especially as we move toward an open standard interface for information exchange. Second might be to standardize HIE sending processes. So that means really looking at workflows and technology and how we can make it easier for providers to actually access and use and send information. And the third I mentioned earlier is the 10% threshold under the EHR incentive program has not really gone up, and I think that's quite low. I'd like to see that a little bit higher, and I think hospitals can make it. And then fourth, and this is kind of an area that I think would be really interesting to explore with you guys, would be to identify high-value HIE use cases. So it really could be that it's not very useful to just send information out for every single one of your patients that are discharged from the hospital. So let's look at specific use cases. Are there certain patient populations that experience more fragmented care for which we really need to focus on getting information out? So there are a lot of next steps that someone could take after looking at this study, and I'd like to do some of them. There's a lot here. So the first would be, like I said, identify high and low value use cases for health information exchange. And one way that this could be done is looking at the patient populations, and if we have some kind of measure of who looked at data, we could really see whether looking at data and sending information leads to better patient outcomes. Another kind of direction I want to take this is looking at network effects. So, what this study kind of looks at is who's in your shared payment network, and then looking at who's in your shared information network, and seeing if those overlap and whether overlap leads to better patient care. And then one interesting kind of question is look at the digital divide. So for who is information being sent, and do they tend to be those with better access to care, better insurance coverage? And if so, there are really important implications here for patients who might have lower access to care and lower quality care. I think something really interesting that's happening here in Oregon is this idea of incorporating social determinants of health data into the EHR. And I'd like to kind of explore what this means for patient care and care coordination. So a lot of low-income patients, homeless patients, patients who don't have a lot of access have really fragmented care. And in theory, these are the folks who really need, who could really benefit from technology like health information exchange. So looking at what's happening specifically with this patient population would be of interest to me. And similarly, CCO 2.0 is trying to link data on behavioral health with medical data. And so what are the implications of that, and what can we do with that data? And do patients even want their medical providers knowing about their behavioral health and social service access? And then something I kind of picked up at Carnegie Mellon, and I would love to kind of explore, would be how we can use text analytics to kind of support this kind of work. So one kind of related maybe idea is just looking at like free text in the EHR. There's a lot of that isn't being used, and understanding how information contained in those clinical notes can improve patient care. So yeah, that is this study in a nutshell, and I'd be interested in hearing your thoughts and discussing more, and if anyone wants to chat, I'm around. Thank you.
Thanks. I really enjoyed that. One question I had based off of some of your later comments was, you talked about maybe we could look at maybe meaningful use of HIE versus just any use. And I'm wondering your first thoughts on what would be a good measure of meaningful use of HIE if you had to take a first hack at that.
Yeah, that's a really great question. I think that really comes down to understanding, for me, it comes down to understanding the use cases. So I think meaningful use of HIE, and that's kind of what I was trying to get at. It isn't just about sending data like the Meaningful Use program is trying to capture. It's about who are you sending data to and for what patients, and how is that data being used, and what data is it? So a lot of people have criticized the summary of care record document because it seems kind of innocuous. It's not very useful to a lot of physicians. And so that's a good question, and I have yet to answer it. And I think it really depends on the patient and the provider needs. Yeah, that's a great question. Thank you.
Yeah, I was going to ask the exact same question, but maybe putting it at a kind of a different angle of if you could drill down into the actual uses. I mean, your data is at an organizational level,
Right.
and which you said as a limitation, but I can think of situations, maybe for example, like OHSU is an integrated delivery system. And I know that we do a fair amount of HIE, but probably for a large number of our patients, they get all of their care in the OHSU system. So HIE is not necessarily that important for them, although it may be important for others. So trying to identify the benefits of HIE, from this sort of framework, is somewhat limiting. But I guess maybe the other question I was going to ask, which I will still ask, there are, there's new rules that have been proposed under the 21st Century Cures Act.
Yeah.
And they're going to be announced any day now. That actually may sort of make it easier to do HIE because you don't necessarily need to kind of connect to an HIE organization. It's just now part of how data gets transferred.
Right.
So how might that impact kind of further work that you're doing, because it may actually HIE may be accessible to everyone.
Yeah. I think that's those are two really great points. I think kind of speaking to your first point about OHSU being an integrated system, it would. So part of my thought process behind this is looking at not just looking at integrated systems as still different kind of provider groups, but all within the same system that share information. And if you can look at maybe the metadata behind access to information, it's almost an interesting kind of experiment in a way, looking at an integrated health system who have shared information and seeing whether that results in better outcomes than, say, another system. I mean, there's a lot of confounding factors in there, but where this really applies might be Pittsburgh was a great example where I got my master's degree. We had two really powerful healthcare systems, and they refused to talk to each other. And looking at something like that, where you have patients who are going to both systems, and information is not necessarily being transferred, and comparing kind of how information exchange might actually impact patient outcomes. And I think that goes back to the question you asked, was it might for some patients, and it might not for the majority of patients, and we don't know. And then your question about the 21st Century Cures Act, it's interesting what's happening. I think there's a lot of talk about moving to, I think you're referring to the open APIs, or and that would be interesting, provided that there are policies in place that allow and really encourage more third-party kind of innovation in that space. So I think where we might see that kind of world of interconnectivity really happen would be if we can get a lot of companies, but tech companies that can facilitate those bridges. And even though the policies are in place, there's a lot of kind of we still have a long way to go even with that technology. So there was I forget the name of this person at AMIA last year who kind of did just to show what open APIs could look like. Took, in theory, the same they had the same standards and took two EHRs and kind of mapped them onto each other and just showed how much was missing or how much error there was. And this was just in like medication information. So I think we still have a long way to go to really achieving that kind of open environment. But the policy framework, I think, is moving in that direction. Yeah, Epic is not. Epic is a kind of almost. I'm gonna stop talking about Epic unless anyone wants to know my thoughts on Epic. But yeah, it's a good question.
So I'm Steve Kosaki. I'm kind of operationally responsible for a lot of the HIE at OHSU. We can talk about some of the things afterwards.
Yeah.
There's kind of one observation and then just kind of a question. I feel like a lot of the idea of the benefit of HIE is predicated on the fact that it's going to reduce waste in healthcare and overuse.
Yeah.
My sense, though, I have, when I look at the waste literature, and there is kind of an overuse literature out there, I don't, there's a number of different, what I'll just call hypotheses at this point about what's driving that. And I wonder if that we sort of overestimate the effect of missing information sometimes on what's driving waste in healthcare, and that it isn't, all the waste isn't, my sense is maybe all the waste is, it's much more structural alignment incentive problems than it is just missing information. But do you have a good sense of how well we've constrained kind of, information needs as driving waste in healthcare?
That's a really good question. That is a really good question. It touches on a lot of kind of the other stuff I'm looking at. And I think in answering that question, I'm finding like a large part of my research kind of focuses on technology. But then in order to answer those kind of questions, you end up having to look at the other parts of the healthcare system. In terms of looking at the actual like information aspect of fragmentation and how that contributes to the overall picture, I don't know of anyone who's done that kind of scoping work, and that would be an interesting area to look at. I do know that you're right, a lot of the kind of use cases that kind of predict information exchange being helpful to cost looks at like redundancy or really emergency department visits is kind of a really big one. Sorry, I had a thought there. Something I learned recently, and I was like, that's amazing. This idea of care coordination might actually not necessarily saving health systems money. So a lot of the literature on care coordination in general, not just information exchange, finds that, yes, care quality is improving a little bit, but when you actually look at the cost-benefit analysis, it actually costs more money to provide more high, coordinated care. And I guess when you really think of it that way, in the sense of the large picture, it does make sense. So those are really valid questions. Yeah.
Yeah. The other thing, thanks for that response. The other one I was interested in is, my kind of view of this is that there's very little in terms of a framework for implementation, right? And so each individual organization is basically, the vendor kind of gives them some tools, sort of, and it's basically turn it on.
Yeah.
Basically. But in terms of how you publish your provider directory, how often you update it, what you tell other organizations to send to, how you distribute those messages, what those messages are packaged in, how they get sent, that's all in the wild.
Yeah.
And so it's like, this stuff, people are just pumping it out. Everything was about sending, right?
Yeah.
There's no read receipt built into direct. And we really don't have a good sense of how that process, and so, all the trust and agreement is kind of just, no one's really defined how that process needs to work. And my sense is, we're just going to continue pumping out useless information until someone sort of does that hard work.
Yeah, that's a really great point, and a big criticism of the health information organization kind of movement that happened a few years ago, this push for the RIOs. So there was a lot of, I don't know if you're familiar, a lot of federal investment in these third-party organizations that were supposed to create those governing frameworks. But there was no standard way, there was no blueprint, there was no guideline. They just said, go for it, take our money, and come up with things. And that's...
And even within the folks who are doing it within a single vendor, that same problem exists.
Oh, yeah.
Actually, either one of you a question. What about TEFCA? Will TEFCA solve these problems, the Trusted Exchange Framework?
I don't know that it's clear yet that it will.
Okay.
I'm not sure it's defined enough at this stage.
Yeah, it's think there's a lot of different forces at play, and not just at the policy level, but there is competition among vendors. This is a big issue. Not just provider competition. Yeah, it's a good question. It's good.
We need total fluidity of the data at the I mean, years ago, I can't remember who it was. It may have been Farzad Mostashari said, EHR vendors should compete on sort of features and interfaces, and the data should be standardized, or the famous Stan Huff quote that I once said, and it got tweeted, so now it's often attributed to me, but it's not me. There should be socialism for the data and capitalism for the EHR. So the data should be sacrosanct, and easily move back and forth. But as you both mentioned, there's obvious challenges to doing that at this time.
And piggybacking off of what Steve was saying, there's waste in just the reordering of a lab that's already been done, but there's also system waste as far as the salaries of all those people who have to go scrub the charts or call the family again to ask why this hasn't been done, or any number of things. Has there been any, and that might be caught before it results in additional hospital admissions or ED visits, because the care is eventually getting coordinated.
Yeah.
Is there any work on the cost of the administrative burden of even successfully getting that data from other places?
Yeah, and that's a really great point, and there has been work on that. It's a few years old, so I'm having trouble kind of recalling what they found, but yes, I recall working with someone on a project at U of M, and before he does any surgery, he has his secretary call the patient's providers and gather all the faxes, and literally piles of these papers that she then types into the EHR manually. And this is at a really fancy hospital with really fancy technology. And yeah, it's kind of that kind of redundancy, that work, that manpower that I think we don't often think about as a benefit of this kind of technology. So yes, there is work on it, and I can find that paper and send it to you. Yeah.
Great, thank you.
Yeah.
So I might just add to that. When you're thinking about high-value use cases, I think what's happened is we've gone after the nebulous use case of it'll improve care.
Right? That's what my opinion HIE has done. I think the really high-value use cases are those operational things that have some touch on care. Like we're working on regionally doing HIE referrals. Right? There's a very green ROI on that. We have hundreds of people processing paper and referrals, and if we can package those electronically. And so I think those are the things. The other one, that sort of sits outside, the PDMP integration, even though it's kind of owned all by one vendor in the United States, like that's a very high value use case. And then so prescription drug monitoring programs.
Right, yeah.
And then the other one is your state registries for immunizations.
Yeah.
Right? But I think from my vantage point, the HIE that I see as valuable that the organization could figure out how to organize around and get trust and agreement are those, those low-hanging fruit business cases where there are these very paper-heavy processes, but the nebulous, we're just going to let all the information out there and somehow it's going to improve care is kind of, it's pretty pie in the sky.
Yeah.
And I think we're seeing a lot of the effects. So many organizations are actually taking those meaningful use to summaries of care and just black holing them. They don't route them at anybody.
Yeah, exactly. I mean, that was the big criticism behind requiring them in that policy is they don't really do anything.
This is really interesting. Where did direct messaging go?
Oh.
So because we use email all the time and we send documents back and forth, and the idea was that this would be a secure, HIPAA-compliant email, provider to provider, right? And you could easily regulate the format of a domain name so that you could send it across, and the content would just be whatever media you attach to it. And that's one question. The other question is, has HL7 sort of purposely not jumped into this type of question? Have they just said we provide the language but not the policy, or have there been organizations, nonprofits or whatever, with similar missions to HL7 who've tried to say, hey, look, this is how we should do it?
I don't know where direct has gone
Yeah.
in response to your first question. And that's something I'd be interested in hearing you guys. I haven't studied direct as much. It's kind of just seemed, at least from the policy that I've read, is just it's happened and it's there. The question about HL7 is a good one, and I do believe it's been adopted in the newest kind of certification. So I guess your question about whether there's an organization out there that's really pushing for something.
Yeah, because there's clearly a whole bunch of build or standardizations to do on
Yeah.
not the format of the daily basis, but how you're going to configure that is what I think Steve's referring to. Is that right? Would you agree?
Yeah, so that kind of got referring to Bill's comment more like not just about how data is captured and stored, but actually the governing processes that go above it. Yeah, and that, I believe there was an attempt to put something together by ONC. Last I read, like, was last year, they actually had started putting together like a governing framework that they wanted to push out. I think they're just still working on it, is the idea. Yeah, yeah.
With Bill's question, I mean, I think that's somewhat of what TEFCA is going to try to accomplish.
Yeah, I'm not,
Another regulatory acronym from ONC.
Trusted Exchange Framework.
oh, okay.
But it's supposed to kind of better define governance. I think,
Yeah.
I guess I should probably speak in the microphone. I think direct still exists. Yeah, yeah.
Most people are pumping the Meaningful Use 2 stuff that's going out.
Yeah.
The direct.
But again, what you see is, what address does it go out to? The receiving organization, some of them, everybody's got the same direct address.
Mm-hmm.
People are updating it, has that information.
Right. Or even if it's being the read receipts, it kind of gets to the same problem with medications and closing that loop. And
I mean, you can look at the giant use case of email. I'm not sure email's going to solve a lot of problems. Having something that just sort of calls that same framework seems a little.
But I think that, all direct really is secure email with this kind of layer on top of it. But, I don't know, I hear about people emailing stuff, from provider to provider all the time. I mean, actually, you probably know more about this than I would, but, and then somehow it gets put into Epic. Someone sends a picture of something. That's kind of what direct was for. It's just a direct point to point. But I don't know how much a non-direct direct communication there is versus the use of direct.
I mean, there's a fair bit. There's not much. Organizationally, in Oregon, there's not a whole lot of direct to direct. Yeah, some of the organizations haven't really implemented on the receipt side.
I do wonder, the framework perspective that you chose, and if that gave you a bit of the answer you got. So from the hospital, does a hospital's participation in ACO facilitate their use of HIE? I do wonder if you looked at it from the other end and said an affiliated partner's
yeah.
involvement in an ACO, does that change their uptake of that? Because I know from perspective of mine being outside of a hospital system, if you're in an ACO, you're going to use those systems more because it's part of the system. Now, why? You couldn't answer that. But the perspective, you don't have all those competing priorities that Steve and Bill talked about, that look at Epic itself and looking at trying to prevent leak. You spend a lot of time in trying to prevent leakage out of your system, and that has a capital return for you, or sorry, a financial return for you. But why would I make it really easy to send outside of an organization other than it's good for the patient?
Yeah, that's a really great question. I hope this answers or talks on your question. So yeah, I think that was actually my if I had a goal in mind for my dissertation when I was coming up with it, was actually to look at the provider side of or primary care providers specifically, and their uptake of HIE, because I think it's a lot harder and what's happening with provider consolidation, all this other stuff kind of speaks to some of those challenges. But it was hard to get data on that. And there's some surveys out there that can be used, but it was a really great question. And there's, so one other, I didn't put it up there, but I did look at network effects, so looking at what providers were in the same ACO and whether that kind of facilitated some kind of patient sharing kind of changes in patient sharing patterns. What I really wanted to look at was whether that facilitated information exchange. And it's hard to get data on information exchange at the provider level, but that would be a direction I would hope to go in. And there is kind of a study that we're working on now that looks at kind of that keeping patient care within the network and whether that has an impact on outcomes. And especially, so we looked at MSSP ACOs in the country, and we're finding that ACOs that were able to keep more of their patient care within their network actually were managing to lower their costs more so than ACOs that had patients going everywhere else. So there is something there, and I think information might be a big part of it. There is, I could talk more about that, but yeah, that's a really great question. Thank you.
Well, good. Thank you very much. And I'm sure we'll all be talking more with you now that you're in the neighborhood.
Yeah, thank you. Thank you
Thanks
for
a lot.
having me.